Good evening, everyone. We're just going to wait another minute or so so we can have a few more people join the call here. Okay, I think we're going to get started. So welcome to SOPE's Education Speed webinar tonight on Intro to TEE. I'm Dawn Park. I'm a sonographer at Nationwide Children's, and my co-chair is Carolyn Wilhelm with me as well. And we're really excited to have you guys here tonight. We're really excited about the talks tonight. Next slide. We want to thank our sponsors. We've gotten a lot more sponsorships, which we greatly appreciate. If anybody has any interest in that, you can reach out to our management team at sopeecho.org. And then you can also follow us on social media. There are a lot of different options for you. And so whichever one you'd like, our communications team does a really great job with that. And now I will have Carolyn take over. Also, our sponsor tonight is Rady Children, so stay on at the end of the presentation. We will have just a few quick minutes from them talking about Rady tonight. Carolyn?
Our moderators for this evening's session are Dr. Libby LaSalle. She's a fourth-year non-invasive imaging fellow at Rady Children's Hospital. And then also Dr. Nitin Madan, who is from Children's Mercy in Kansas City.
Good evening, everyone. It is my pleasure to welcome Dr. Puchalski as our first speaker for this evening. He is co-director of the Heart Institute and chief of pediatric cardiology at Johns Hopkins All Children's since the year 2020. Prior to this, he spent almost 20 years at the University of Utah after a fellowship in pediatric cardiology at UCSF. He is also the first author on the JACE 2019 guideline paper on comprehensive TE evaluation in children, which is an excellent resource for all. And I look forward to his talk on this topic today.
Thanks very much. Good evening, everyone. Happy almost Halloween. As Dr. Madan said, I was involved in the paper here, for guidelines for performing comprehensive transesophageal echo exam. And what I thought I would do is, in our time, run through the tomographic views and how we obtain them, and kind of talk as I'm going about how we utilize sweeps and modifications, and then basically how the structure was laid out, and then at the end or towards the end, talk more specifically about how we laid out congenital heart disease and sort of tips and tricks. So typically we recommended starting in the mid-esophageal plane, and you'll see that what we considered our home base was the 4-chamber view. And on the right-hand side of the screen here, we talk about this transducer angle, and you'll see that change from plane to plane. So you can change your degrees from 0 moving towards 180 degrees is sort of how we did the mid-esophageal views. And then all the way over here on the right-hand side, we talk about the structures that are imaged within each imaging plane. So the mid-esophageal 4-chamber view, you see the probe is located in the esophagus, sort of directly behind the heart, giving you almost a standard 4-chamber plane. And then as you tip a little superior, you can pick up the left ventricular outflow tract and aortic valve there, giving you the 5-chamber plane. For the third view, you rotate the transducer towards 50 to 70 degrees, and you can profile the mitral valve, specifically the scallops that are listed there on the right-hand side. And you'll notice in most of these diagrams, we're giving you a range from 50 to 70, emphasizing that depending on what the heart looks like or even in its position, the recommendation would be to move slowly in a sweep from one plane or one imaging degree to another to find the best profile for that view. So moving forward, if you keep going towards 90 degrees, you'll pick up the mid-esophageal two-chamber view here. And then continuing on towards 100, usually I'm around 120, but it can be up to 140 degrees, is a really nice profile of the left ventricular outflow tract. And then to really look more at the ascending aorta, you actually withdraw the probe. It's hard to see that in the diagram, but if you withdraw the probe just a little bit, you come out of the more ventricular plane up into the ascending aorta, which can be really nice for patients with a dilated root like Marfan's or supravalvular aortic stenosis. Back at the 90 to 110 plane, if you rotate your hand a little bit rightward, you can pick up the mid-esophageal ascending aorta sort of laid out in long axis with the RPA behind it. And then on the next view, you're picking up the RPA as it swings around behind the aorta in cross section. And you can utilize this view for things like the bidirectional Glenn, for instance. If you rotate more rightward, you're going to pick up the right pulmonary veins here, as well as the SVC. And then the reason why this plane 10 is highlighted is the difference between the pediatric congenital guidelines and the adult guidelines. So in the PEDS guidelines, we recommended rotating all the way leftward in at a 90 to 110 degree to pick up the both pulmonary veins coming from the left. And then the standard view there with the left atrial appendage right below it at 11, and then rotating back towards 25 to 30 degrees or so to get the aortic valve on FOS. And this is a nice view with slight rotation left-right to pick up the left coronary artery and the right coronary artery. For the congenital cases, a lot of them involve right ventricular outflow tract like TETs and double outlets. And so the RV inflow outflow view is a nice view to use for that. And then you move to the bicaval view here in image 15, which is a really nice plane to profile the atrial septum and can come in handy for atrial septal defects, especially a sinus venosus type defect. Moving on from the mid-esophageal view, we recommended the transgastric views next. This view 16 was different from the adult views in that we're looking at the hepatic veins entering into the IVC. And we felt that this was important because we have many patients like in heterotaxy syndrome that may have anomalous hepatic venous drainage. You can also have total veins below the diaphragm that comes in this location that can be helpful, as well as partial veins like a scimitar can come down into this imaging plane. So the standard views basal short axis looking at ventricular function, both in 17 and 18, as well as here 19, just lower down in cross section at the apex. And then in the long axis, again, looking at the mitral valve and left ventricular outflow. In the deep transgastric imaging plane, I've grown to sort of love this view. You really get a nice alignment with the left ventricular outflow tract, and even with rotation, you can pick up the right ventricular outflow tract as well. And I think profiling ventricular septal defects as well as malalignment of the ventricular septum can be done really efficiently here in the deep transgastric view, as well as placing atrial septal device closure in the cath lab. This atrial septal view, image 23, has proven to be super helpful. Moving up to the upper esophageal view, this is more focusing on the ascending aorta you see in 24 and 25. And then again, more for our congenital, looking at the pulmonary artery here in 26 is different than the adults. And then the last two views, looking at the descending aorta from that upper esophageal view, both in cross-section and in long axis. So we emphasize that any exam on patients with congenital heart disease should be structure-based from multiple views and include 2D color and Doppler. Although I didn't talk about it as much, the color and Doppler in each of those views can be really helpful for you. So in summary, these 28 views encompass a comprehensive exam, but not every view is necessary for every patient every time. These really serve as a starting point for congenital heart disease evaluation and can be altered as needed. And the views often need to be modified or tailored with sweeps to help capture all the information. So what I mentioned here is specifically around congenital heart disease that we included in towards the end of the document is this it's not really a diagram, it's more like a table, but it has the heart disease on the left-hand side here, and then the primary lesion that you're looking for in the center, it will tell you which is the best view. And so, for instance, the mid-esophageal four-chamber view or view 1, looking at an atrial septal defect. And then what I really liked is over here on the right-hand side, is common lesions that are associated with your primary condition. So in this case, an atrial septal defect, it's advising you to sort of be on the lookout for partial anomalous pulmonary venous return, and then which views may be helpful to assess for that anomalous pulmonary venous drainage. So for ventricular septal defect, again, views that would be helpful. And then over here, paying attention to double chamber right ventricle, as well as aortic valve prolapse, and because sometimes you can get some aortic insufficiency. And then for atrial septal defects, paying attention to subaortic obstruction, as well as just the valve itself. And so moving on, we talked about Ebstein's anomaly and assessing for non-compaction of the left ventricle, which can be associated with Ebstein. And then for conal truncal defects, the position of the great arteries and the location of the VSD are sort of the critical primary features. But again, you can assess other things like the right ventricle and any other valvular abnormalities and suggestions of the appropriate views. Similarly, for tetralogy of Fallot, double outlet right ventricle and L transposition, again, talking about both the physiologic repair as well as an anatomic repair, since you might see both in your practice. Truncus arteriosus, and then the arterial switch, and suggestions about how best to assess the coronary arteries both before and after repair, with assessing the Rastelli as well as the atrial switch. And then finally, we touched on staged single ventricle palliation, both the Norwood, Glenn, and then finally the Fontan, and suggestions of how to evaluate the lateral tunnel or extracardiac connection, as well as looking for clots. Thank you very much.
Thank you so much, Dr. Polchowski. That was a very informative and great review of the text. Dr. Himesh Vyas is an associate professor of pediatrics at the University of Florida. He specializes in interventional cardiology and cardiac imaging, and we're very excited to hear his talk as well.
So thank you so much to the organizers and to the moderators, and good evening and welcome to the viewers. So I'm going to go over a couple of case examples that illustrate the utility of and some of the pitfalls of TE in the operating room and in the cath lab. I have no disclosures. So let's dive right in. We'll start with the first case is a curious case of an ASD that wasn't. So this is a 12-year-old male who was incidentally diagnosed with an ASD due to a heart murmur and then was referred for transcatheter closure. The exam showed a grade 2 out of 6 pulmonary systolic ejection murmur, wide split second heart sound. The ECG showed right ventricular enlargement, and an echocardiogram showed right heart dilation, and inferiorly located secundum ASD, and a smaller, more superior fenestration, all with left to right shunting. And here's some of the transthoracic echo images from the clinic. I can use my pointer here, and that'll show you this multiple fenestrations with the inferior by the IVC, and then a more superior fenestration. On the right-hand panel is the four-chamber view, the apical four-chamber view, and you do see that there is some right heart dilation. So we think that this is a significant ASD. This patient, we discussed transcatheter closure and surgical closure. And given the location of the ASD, there's a possibility we could close it potentially with one larger device. But there's also a possibility we may not be able to get the entire IVC part of the defect. So after discussion, the family elected to move forward with surgical repair. And a TE performed in the operating room is shown here. So some of the transesophageal four-chamber views, there's a small fenestration that you can see here with left to right shunting. And then a short axis view that shows, a pretty intact looking atrial septum higher up. We knew that there's a fenestration lower down by the IVC entrance, and so we get some more imaging. There's maybe an additional smaller fenestration, maybe another fenestration by the coronary sinus. So a couple of small fenestrations, but nothing that looked really significant. And so the TE doc and the surgeon are scratching their head, and the surgeon calls me over to the cath lab. And as all of you know, that's never a good sign when the surgeon says, "Can you come over to the OR?" And he tells me, "Himesh, I don't think that I can operate on this patient. I just don't see, that there is a significant ASD. There are multiple small, fenestrations, but there's not really anything I see that would warrant surgery." What would you do? On one hand, we know that there is significant right heart enlargement. The exam shows that there is evidence of a significant shunt. There is right heart enlargement. And so I knew that the surgeon would not operate unless we proved that there is a significant shunt. So we did a mini diagnostic cath in the operating room. We advanced a Swan-Ganz catheter from the access site in the right jugular vein and did a brief sat run. The SVC saturations in the superior vena cava, 78%. Step up to 93% in the pulmonary arteries. This is consistent with a large shunt, a QB to QS of over 3:1. So we just had to prove where this defect was. And a more meticulous examination of the IVC-RA junction showed a harder to see perhaps on the TE than sometimes on the transthoracic images even, but a significant shunt right by the IV, where we knew that there would be one by the IVC-RA junction. And that was enough to convince the surgeon to move forward with the surgery. And this is where the kind of the views that Dr. Puchalski talked about with the deep transgastric, looking at the IVC entrance into the right atrium, which almost looks like your subcostal sagittal transthoracic views, can be very, very helpful. So at surgery, they did find a large inferior secundum ASD, multiple fenestrations, which was closed with a pericardial patch, and this patient is doing great. Another case is one of a residual ASD post-transcatheter ASD closure. This is a 26-year-old female who had transcatheter ASD closure elsewhere with an 18 millimeter Amplatzer occluder. And she's now attending vet school in Gainesville and was seen for a routine care by our ACHD team. And she has a transthoracic echo performed, and you can see from the 4-chamber views that the device, and maybe there is some suggestion of a shunt below that, maybe an inferiorly located shunt as well. Just a couple of unusual things. The right heart does look dilated. So that was enough for us to say, well, let's bring this patient in for a heart catheterization and close this residual defect. So at the time of her cath, we noticed a pretty significant step up in saturations, 74 to 88% in the pulmonary arteries. This, is consistent with a QP to QS of 2 to 1, a large left to right shunt, normal pulmonary veins, and no left SVC. Imaging of the ASD device itself to try to see if there was a residual shunt adjacent to the device really didn't show anything very tremendously revealing. The device from the short axis view looks pretty good. There's no anterior shunt. There's no shunt posterior to the defect. From the bicaval views as well, that device looks pretty well positioned with nothing adjacent to the device as we had suspected. So what is the diagnosis? The coronary sinus looked prominent. There was copious flow coming in from the coronary sinus as well. We knew that there's not a left SVC. This was strongly suggestive to us of potentially an unroofed coronary sinus or a coronary sinus type defect. So to prove it, we did a agitated saline contrast study with injecting the coronary sinus. And you see brisk opacification. You can see the catheter here in the left in the coronary sinus. And there's brisk opacification of the left atrium as well as the left ventricle. And this is consistent with an unroofed coronary sinus. So this patient eventually underwent surgical repair of a large residual shunt from an unroofed coronary sinus type ASD. So with those cases, let's touch upon common applications of TE in the OR and the cath lab. In the OR, you're going to usually do the TEE before the case and then after the case. Check for air in the heart coming off of bypass. You're going to check for cardiac function. You're going to look for new or residual shunts. You're going to look for new or residual valvular disease. And then surgically created baffles, pathways, or conduits, new pathways that may have obstruction, or if there were existing ones that may be affected by the type of surgery that was done. So those are the types of more common things, certainly not an exhaustive list. Whereas in the cath lab, it's often more dynamic. You are with us in the cath lab throughout the case. As we are implanting the device, you are guiding us for implanting the device. And so we rely on you for imaging throughout the case. We use this for ASD and VSD closures, baffle punctures, atrial septal punctures, treatment of perivalvular leaks, catheter-directed thrombectomy, and some transcatheter valve implants. For the majority of transcatheter pulmonary valves, we tend to prefer intracardiac echo, though. So some of the applications in the OR that we touched upon. Here's an example of a patient who has a complete AV septal defect, a preoperative study, 3-month-old child with trisomy 21, very large primum ASD and a large inlet VSD, single balanced complete AV canal. This patient post-op study after a 2-patch repair. And what do we see here? We see that there is a residual VSD with left to right shunting, and we see significant left AV valve regurgitation. We see multiple jets of left AV valve regurgitation, and there was also a gradient of about 4 or 5. So, we discussed this with the surgeon, and the surgeon didn't feel that given the valve anatomy, that'd be possible for him to re-repair or to go back on bypass and attempt to repair this valve further for fear of creating more stenosis. So we accepted it as it is at the time. The TE probe needed to be removed soon after the surgery, soon after the TE was done due to poor lung compliance. That's also a bit of a red flag. And on follow-up, this patient had a very difficult course, slow recovery, had a prolonged hospitalization, and over time developed very severe left AV valve regurgitation. So this patient underwent repeat surgery about 8 months later. And this is the pre-bypass study of the second subsequent surgery. And you can see just severe left AV valve regurgitation. He did well after his second surgery in terms of valvular regurgitation. So a couple of takeaways that I'd like to suggest, resist the temptation to quickly render a judgment. This is particularly applicable to folks who are new and are doing TE for the first time or are new attending, and you have an experienced surgeon. A lot of times, and I experience this as well, when you go to the operating room and you get the first one or two images and things may look okay, and your surgeon may tell you, yeah, so that looks great. And you feel the desire to say, yes, that looks great. But resist that temptation. Take some time to get your imaging and then make your statement. Let the surgeon know if you think the residual lesion is significant or not, rather than get into a lot of the semantics of is it mild or moderate or severe. For example, you might argue about that AV valve regurgitation and say, was that moderate or severe? The fact is, I thought that it was significant in that patient. And sometimes the surgeon may not be able to address this issue, but at least you have made it clear what your concerns were. Be prepared for unusual things. This is a case of a 7-year-old female with tetralogy of Fallot, status post-transannular patch repair, who had severe residual pulmonic insufficiency, severe RV enlargement, and mildly reduced RV function. And after discussion, she was put forward for surgical repair, which was performed with a 23-millimeter Inspiris valve. She did very well and was discharged home in 4 days. And here's the TEE, post pulmonic valve replacement. You can see the bioprosthetic pulmonic valve functioning really well, no significant stenosis or insufficiency. And then some of the deep transgastric views that Mike was alluding to, showing the left ventricular outflow tract real well, and maybe a touch of aortic valve insufficiency. This patient comes back for her first post-op visit, clinically doing great. And we see this on the transthoracic echo. What we see here is this RV inflow outflow tract view, and you see continuous shunting from the aorta to the right ventricular outflow tract. So this patient had developed a fistula from the right coronary cusp to the right ventricular outflow tract, exiting just below this bioprosthetic valve. We looked back at the TE images from post, and we certainly did not see it at that time. Could it have been missed? I guess it is certainly possible, but this patient also had a pre-discharge echo that did not show it. So, so we think that it has developed subsequently. And after discussion, this patient returned back to the operating room for repair of this fistula. And the surgeon found a fistula from the right coronary cusp to the RV outflow tract, which was repaired with a small patch of bovine pericardium. Interestingly, if you look at the transesophageal echo at the time of the surgery, it's not quite as obvious. Clearly, you can see that there's something wrong here, but it's not quite as obvious or well seen as on the transthoracic echo. So sometimes, the very anterior location of the right ventricular outflow tract, pulmonic conduits can make that a little bit limiting as well, in terms of what you can see. So always keep an open mind there. Takeaways and conclusions. It takes time to build relationships with your surgeon and your proceduralist in the OR and the cath lab. And I can say this from being on both sides of this procedure. Try to perform as complete an assessment as possible. Limited assessments to address an imminent issue are certainly acceptable, but must be followed by a thorough and complete evaluation. And as proceduralists, we appreciate your attention to detail. Your meticulousness and skill has saved me from disaster many a time. So with that, I'd like to conclude. Thank you.
Thank you so much for your both wonderful talks. I encourage everyone to put their questions in the chat. It looks like we don't have anything quite yet, so I was planning to get us started. Sometimes in the OR, maybe in a post-operative patient, we can have some difficulty with image quality, post-op or with a small child. I don't know if you could speak to some maybe tips and tricks for image optimization that you've acquired over the years, maybe for some people who are just starting out. And I can go to either of you, if anyone.
Certainly, I'm sure Mike will have would be a great resource for that. But in my opinion, we tend to have a very low threshold to move from one modality to another. For example, if you're having trouble imaging part of the heart, and that is the part that is in question, we have no issue with switching to, say, epicardial echo, particularly for things like RV to PA conduits. If you are not, particularly if you can't visualize the distal conduit or the proximal pulmonary arteries, we would switch from one modality to the other, just so we can answer that question. Sometimes in the cath lab, we'll switch from TEE to ICE, and that can be very helpful as well in those particular cases.
Yeah, we do the same thing. We'll switch for anterior most structures, switch to epicardial in the operating room. I've certainly done plenty of transthoracic in the cath lab with a TE probe in. That's totally common. Tips for the small babies. I mean, honestly, don't be afraid of the transgastric views. We did not plan this, in terms of me emphasizing that transgastric, but when I looked at that first case, I was thinking to myself, oh, I bet you that you would have picked up the IVC, because the sinus venosus area can be really hard if you stick to the mid-esophageal views. And so I guess I would just strongly encourage people to not be afraid of looking in more image planes. I think early in my career, I sort of relied or banked on the mid-esophageal, and as I've gotten older, I tend to, as I mentioned, like the transgastric. Even the view there at the end, Himesh, on the coronary fistula, I thought a transgastric, looking up at the RVOT, you would have seen it shooting right down into the right ventricular outflow tract. So
Yeah, great points.
Yes, thank you for those excellent talks, and I couldn't agree more. I think we have to have complete pre-op TTE. Your cases highlighted some of the limitations. Sometimes we don't see some of these structures in TE, and also complete TE as well. So on that, I wondered, Mike, if you utilize because CHD is such a big spectrum, and sometimes you're pushed on time. Do you have a unified protocol that you have all imagers do in every case, or everybody tailors to the specific CHD that they're looking at?
Yeah, I think we kind of do more tailored. I mean, the iCal, for those people, we're all beholden to that. But really, when it comes down to it and we're looking back through, we don't get everything for a detailed iCal in every study. So I would say it's more targeted. I have gotten used to going transgastric first, primarily because historically I was at an institution where we had some perforations, and you just don't know unless you go into the belly first. So in my training, we always started mid-esophageal, and then I adopted going transgastric, and I think that was probably what allowed a little bit more comfort, and that's how I train the fellows as well. So that other than that, going transgastric, deep transgastric, back to mid-esophageal, and up to the aortic views is sort of just my own personal standard.
Thank you. There is one question in the chat. I would like to know how often sites are seeing issues with microtransducers. We've had multiple replacements due to failure of the transducers. We have had some experience, but I'll see what our speakers have to say, and you can chime in on that too.
I think it's been pretty common, frankly. They're very delicate. And I think the way in which you handle the cleaning of those probes is really important, and limiting the I think how you package them up, both bringing them in the operating room and or the cath lab and leaving, is really important. And so if you put them in sort of a foam, the tip like in a foam container, both before and after, we've been able to sort of preserve them a little bit better. But if you bang them around in like a bucket or something, you're going to lose the elements and need to have them replaced more frequently.
I agree. Sometimes they surprise me with the image quality when they are new, and then suddenly it degrades so much. So they're quite fragile, and we have similar experience. Have to be very careful with them. Himesh, I wish to ask, there is more and more availability of ASD devices, especially with the GCA, and you folks are closing larger and larger defects. So utilization of 3D TEE, especially in those who have deficient rims, your experience and thoughts on that.
Yeah, I think it's valuable, especially in terms of determining whether there's adequacy of the rims and so on. The thing is, most of us have trained and have learned to do the procedure with 2D guidance. And so we tend to, at least I tend to rely quite a bit on the 2D TE images, but it can be valuable to know whether, you would have part of the defect that's not covered or part of the defect that is likely to be, parts where the rim is deficient, where if you have a significant deficiency, it might look from 2D imaging like there is deficiency of a rim, but when you do a 3D imaging, that area of the deficiency might actually be quite small, and it is possible to seat a device there. So in those cases, getting that 3D imaging can be more beneficial. In terms of implanting or while the procedure is being done, I rely 100, personally on 2D TE.
Yeah, go ahead, maybe.
I just had a follow-up question about epicardial echo in the OR, and at your institutions, who is doing that? Is it the surgeons who are taking the probe, or is it one of the echo attendings or fellows or someone scrubbing in?
Surgeon at our institution.
At our institution as well. I stand behind them actually, so away from the machine, have the sonographer at the machine and stand behind the surgeon to help them like clock, counterclock, anterior put, so it helps me to be from their viewpoint rather than when I was at the head of the bed and doing it upside down, and then trying to get them to do what I wanted them to do was more complicated.
Thank you.
We do the
That's
same. Go ahead, Himesh.
No, I was going to say that's a great point. I usually end up standing still at the head and kind of trying to get them to direct them to where they need to be. And I'm actually amazed how good a sonographer or the surgeons can be. They are really good and often get what they need, what we all need. But that's a great point, Mike. Maybe standing behind so that we know, it's intuitive what direction they need to scan might be helpful.
Yeah, I find that the senior surgeons, I agree, they can really get the views, but the younger ones don't know how to do it. And then, they will slide across the heart. So if you don't see what they're doing because you're looking at the screen, but you're not paying attention to where their hand is, it can be very frustrating.
Sometimes I challenge our fellows to scan a patient without knowing where the notch is, because very quickly you can realize how the image is going to move, and that helps you train for looking at the image in the OR, because where the surgeon places the notch is always like, you don't know. You got to figure out after you look at the image. So I think that's something I encourage our fellows to try and experiment with. It's a fun exercise.
That is, I hadn't thought of that. It's clever.
It looks like,
Uh,
oh, go ahead. You can.
Yeah, it looks like a follow-up question for you, Mike, that what made you change having the imagers stand behind the surgeon? I think it's for the epicardial. Do all imagers do this now, or is it a case-by-case basis?
I'm not in with the other with the other imagers, so I'm not sure. For me personally, it was born out of some frustration. And I just felt like it was easier for me to sort of look at both things at the same time, their hand position and describing it to them and watching the image at the same time. So personally, it was just easier.
Thank you. Thank you again to both the speakers. I think we're right about time where I let our Dawn and Caroline jump back in.
Yes, thank you both for such great talks, and thank you to our sponsor, Rady Children's, for this evening. Again, thank you to the rest of our sponsors as well. And if you're interested in becoming an institutional sponsor, please reach out to us. Follow us on social media and see all the great things that SOPE is doing. And please join us for our next SOAP Speed session, where we're going to be talking about the screening for the competitive athlete. We have moved up that presentation a little bit to November 18th, so before the holidays, at the same time, 8 p.m. Eastern Standard Time. We're going to now hear from our sponsor for the evening, Rady Children. So I'd like to welcome Dr. Fraser Golding.
Hello, can you hear me?
Yes.
Great. Maybe I'll share my screen here and start that. So thanks very much for the time. I just wanted to give an overview of the lab and our team. So we are a group of 10 echocardiographers, and we met Dr. LaSalle, who's doing a 4th year of advanced imaging spread out over 2 years. We have a fun group of sonographers. We have 19 actually. And this is, just a small number of them. Here are some pictures of us. This was kind of a group outing. And then actually this picture in the middle is one of our sonographers at Medical Academy, where high school students are coming in and learning about, on this particular day, all different elements of jobs in pediatric cardiology, from physicians to sonographers to different technicians throughout the Heart Institute. Libby, I'll put you on the spot here. So Libby is our advanced fellow. She's doing 2 years of fellowship. We don't have funding for a full fellowship, so she is supporting her fellowship by doing some clinical work with us. So that's why we're spreading her fellowship over 2 years. And her areas of interest are echo and fetal echo. And she actually, in her core year, presented at ASC and helped. She presented this year an interesting case, and I'll highlight those just quickly in a second. She's also done presentations at a local group, the Southern Society for Southern California Pediatric Echocardiography. So we have a group from CHLA, UCLA, Cedars-Sinai, CHOC, which is now Rady Children's Health Orange, as well as us at Rady's, who have an in-person meeting every year and several webinars on topics of interest. So Libby has presented at those as well. She's developing a survey that I hope to send out through SOAP about some reporting elements and qualitative and quantitative measures. So when that's ready, hopefully we'll leverage SOAP to get that out to all of the different sites across the country. and also working on an institutional QI project for study completeness, because we have found a few deficits as we've expanded our group of sonographers and readers. So more to come on that. Just mentioning her ASE presentations, she had a really interesting presentation of a case of a double inlet left ventricle where the left-sided AV valve actually co-opted with the septum, and the kind of what would have been a mural leaflet was either deficient or adhered almost abstenoid to the free wall of the left atrium. So it was really co-opting with the septum. And we had some 3D images, and she helped one of our core fellows present a case of a very acute destructive polyvalvular endocarditis, which turned out to be a glycogen storage disease, which acutely affected all valves over a very short period of time. From our sonographers, we've got 12 full-time, 4 per diem, 2 part-time, and we now have our educator. We use, like many of you, Syngo Dynamics. We also have a fleet of mainly GE and Epic systems, and we do about 17,000 echoes per year. And we use multiple satellite clinics. We have fetal at the university and at the Children's Hospital, and we also receive a lot of echoes from the nurseries around San Diego County. This year, we're working at incorporating Lumason into our oncology clinic. We were successful in putting in place our echo educator, and we're working on our REDCap, which I'll show you a few slides, which some of you have seen that already. Exciting, we have our 3D echo, which collaborate with our CT and MRI, and also now our fetal MRI.
Nag-picnic din ang grupo at may kilig na hatid.
Okay. I want to introduce Lisa Fargas via kind of image playground on my Apple iPhone. I took that and created a picture of her, who has just started as our educator, has a long history in education. But we're having her shore up some of our fellows teaching with pre-rotation assessments, midway assessments, and supervised scans at the end of their echo rotations. So we have a first year boot camp that we've been doing for the past 3 years. And Lisa's been instrumental in some of her teaching in that. She has a really unique way to approach to teaching fellows. And then with our sonographers, what she's really been doing is finding out from them some knowledge gaps or areas of learning that are of particular interest of them. And she had a really great session on ECMO with bringing in our ECMO specialists to really go over with the sonographers, all the different systems and catheters that are in place in the hospital. So really kind of focusing on what the sonographers want to see. I shared with you before, kind of converting a sort of PowerPoint kind of presentation of echo kind of morbidity and quality things into now REDCap submissions, where we can submit cases. We launch it through Syngo Dynamics. So we use the third-party launcher. It really just allows you to launch either applications or web pages from within Syngo. So just a quick way to get to that, where we kind of will document based on some of the Boston work on how you categorize errors in a group setting. So more to come on this, but we're actually generating lots of submissions, which is great for overall quality. Kind of exciting at the hospital, there is a new tower going up, a 7th-floor intensive care unit and emergency pavilion tower, which should open in probably 2028. And the cardiac will be on the 4th floor for a cardiac ICU, but it'll have the ORs kind of centralized on the same area, kind of meeting the wings of the wards, where the ORs will be in the center. There'll be a cath lab there. So very exciting for the cardiac team. We do some collaboration with Syngo through Siemens, where we're looking at hopefully their new architecture, which will be coming down the road in a couple of years, probably having a pre-development system here to make sure it kind of works in a clinical environment. And we're hoping to become, or we're working to become luminary site for Canon Medical, which has a new ultrasound system with new pediatric probes. What I find interesting in this, the color and kind of power Doppler imaging is really quite phenomenal and sensitive. So hoping that that is something that I'll be able to show more of. And kind of some fun things. Here's a group of us at ASE in 2024. And this is Eleanor Schukart, our fetal MRI doc, who also does fetal echo, and Lisa, who won the Phoenix Case Presentation Award, the Norman Silverman Chest Pain Award. So this is kind of some big high-level highlights, and we'll stop sharing there. And just really shout out to all of the sonographers at Rady Children's who do fantastic work and are very busy echocardiographers reading those 17,000 echoes a year. And Libby, we put a lot of pressure on you to kind of jump in whenever we have anything interesting, because you are our target as our imaging fellow.
Okay, thank you so much. That was really great to hear all the wonderful things you guys are doing at Rady. And yes, thanks, Libby, for moderating with us as well tonight. So again, thank you to everybody, to Dr. Brachowski and Dr. Vyas, and Dr. Maiden and Dr. LaSalle. We really appreciate everybody's time tonight. I know I had a really good time listening to all the great things you guys do in the T. As a sonographer, the lone sonographer up here, really, I appreciate all the work that you guys do, and it's pretty impressive, the images that you guys can get. So I hope everybody has a good night. Enjoy your Halloween in a couple nights. We will see you guys November 18th, the third Tuesday of the month. And we're going to talk about some athletic hearts that night. So everybody have a good night, and thank you so much for joining us.
Thank you.
Thank
Thank you.
you.
Nice, thank you. Thanks, Don.